So over the course of the next 25 to 30 minutes, what I'm going to try and focus on is some normal imaging anatomy of the anterior skull base, and then review a little bit of the common pathologies. Now, the skull base anatomy can look challenging, but it's essentially made up of 5 different bones: the frontal, ethmoidal, sphenoidal, temporal, and occipital. And if you focus more on the anterior skull base, it's primarily the frontal, ethmoidal, and sphenoidal. The ethmoidal primarily composing the central midline portion. The majority otherwise is contributed by the frontal and the sphenoidal bones. Now, it's better to see this anatomy on cross-sectional imaging, so we'll go over a little bit of the important anatomy on image-by-image basis. So what is the anterior skull base? It's portion of the skull base that prevents your brain from falling into your nose or your orbits, right? It's as simple as that. It separates the anterior cranial fossa from the orbit and the paranasal sinuses. The floor is essentially the roof of the orbit, the roof of the nasal cavity, and the roof of the ethmoidal sinuses. If you look at it in a different plane, the anterior border of the anterior skull base is formed by the posterior wall of the frontal sinuses, and the posterior border is essentially formed by portions of the lesser wing of the sphenoid bone and the anterior clinoid process. And this anatomy is easy to appreciate on cross-sectional imaging. So let's do it on an image-by-image basis. Let's start quite anterior, where we are not clearly seeing the structure called the crista galli, so we are somewhere in this location here. This is where a normal structure called the foramen cecum is present in the fetus. This structure might be present in the adult as well, and if it is wide and patent, it can result to lead to a lot of congenital malformation. So normally the foramen cecum ends blindly. Occasionally it can be quite small and serve as a communication for a venous structure going from, say, the superior sagittal sinus in the intracranial compartment to some of the draining veins in the nasal cavities. So it is very difficult to see the foramen cecum unless it is quite big. You go a little bit more posterior, you get this spear-shaped structure called the crista galli, which essentially stands for the spear-shaped comb of the rooster. So it just stands for the crest of the rooster because it looks like the top of the rooster's head. This is an important structure because the falx cerebri is attached to it, and if you can identify the crista galli, it's possible to then identify important anatomy on either side of the crista galli. Now on CT, the crista galli is going to look like bone. On MRI, it can appear very bright on T1 weighted images, and do not be surprised because it is just composed of marrow fat. You move a little bit more lateral, then you have the anatomy change its landscape a little bit. So we have 3 important structures that show up in the anterior skull base. Number 1 is the roof of the ethmoidal cavity, which we will call the fovea ethmoidalis. Number 2 is that sloping portion that then connects to the cribriform plate, so we'll call it the lateral lamella. And the third is the cribriform plate itself. So the cribriform plate essentially has a sieve-like appearance, which is why it's called cribriform. So a lot of the olfactory nerves communicate through the cribriform plate into the intracranial compartment. And this is another picture, blown up picture showing the fovea ethmoidalis, the lateral lamella, and the cribriform plate. This anatomy is important to appreciate because the ENT surgeons are often looking at the distance between the top of the fovea ethmoidalis and the top of the cribriform plate. And that distance is determined by the slope of the lateral lamella. And the further the cribriform plate sinks in relationship to the fovea ethmoidalis, the more difficult it is for the surgeon to reliably go in there without causing risk to major structures. So there is a classification which defines the distance between the top of the cribriform plate and the top of the fovea ethmoidalis. It's called the Quiros classification. So if you're interested, you should probably mention the distance in your reports. Now on MRI, we may not be able to see these structures very clearly, but you do see some additional soft tissue structures. So you will see these soft tissue densities or intensities which are surrounded by CSF, and these are portions of the olfactory bulbs and the olfactory tracts going more posteriorly. Moving a little bit more posterior, the surface now changes to more of a flattened portion, which we call the planum sphenoidale. It's formed by portion of the sphenoidal bone. And this is where your olfactory tracts and portions of your frontal lobes primarily rest. And if you track it a little bit more posterior, you see these bony projections laterally. And these are important to identify. These are the anterior clinoid processes. And the anterior clinoid process forms a very important landmark for identifying where the optic canal is, which is right here, which is along the medial aspect. And if you identify the anterior clinoid process and you drop a vertical line it'll almost certainly cut through another foramen which is important in skull-base imaging, which is the foramen rotundum. And if you identify the foramen rotundum and move a little bit inferior and a little bit medial, you will be able to identify a small foramen called the Vidian canal. It's not shown on this particular image, but if you scroll anterior and posterior, you should be able to identify both of these foramina, the foramen rotundum carrying the maxillary division of the trigeminal nerve, and the Vidian canal primarily composed of the Vidian nerve. And these structures are all important in anterior skull-base imaging because once you have tumors develop in various locations, you're trying to look for intracranial spread through various skull-base foramina. Now, why do we want to image the skull base? For a long time, skull-base surgery involved opening up the frontal bone and having extensive surgery in craniotomy performed. But this was revolutionized in the last 50 years or so by developing endoscopic techniques, so-called minimally invasive surgeries. And majority of the skull base is not accessible for clinical evaluation. Therefore, you want to provide good quality images where we can detect lesions, assess their extent, and if possible, try and differentiate benign and malignant lesions. This helps our ENT surgeons tremendously. You also can provide information about resectability of lesions. So all they can see is the mucosal surface, to some degree the submucosal part, but we can see the deeper extent. We can see if lesions are extending into the intracranial compartment, are they involving the dura, is it invading into the orbits? Sometimes this information makes the lesions unresectable. Especially in the postoperative setting, imaging is crucial because once you take out a tumor and put in a graft or a flap, all you can see is the surface. You do not know if there's a recurrence on the inner side of the flap, and therefore imaging is key for making that evaluation. Now you have two choices. You have CT and MRI for skull-base imaging, and I would say both are complementary. They provide different types of information. CT is essentially used for assessing the osseous anatomy, so it's very good for detecting fractures, defects in the bone, the presence of lesions which look like they have a fibrous or an osseous component, and to look for sclerosis. CT also is good for looking at the neurovascular foramina such as the foramen rotundum, but you cannot directly demonstrate the nerve itself on CT. It's only an indirect sign. So if the foramen rotundum is expanded on one side, it's an indirect sign that there is something wrong. There is something expanding the foramen. Maybe the tumor has a perineural spread and it's slowly expanding that foramen, but you don't see the nerve directly. On the other hand, MRI can provide a direct visualization of tumor extension into the intracranial compartment. It can provide information on whether the tumor is extending into the orbits. And more importantly, you can actually see perineural spread directly. You can see involvement of blood vessels directly. And in contrast to CT, where you can just see the cortical involvement, on MR you can actually see bone marrow involvement directly as well. So both of these are complementary modalities. If you want to develop a good protocol for skull-base imaging, it's important to remember that the structures are so small, so you want to acquire thin sections. So most institutions acquire 0.63 or 1.25 millimeter sections on CT, and then you can reconstruct it in different planes. Now with the advent of multi-detector 64 slice CT and beyond, it's possible to acquire in just one particular plane and then reconstruct it without losing resolution in the other planes. So you're not doubling on the radiation dose. And if you are developing an MRI protocol to look at the skull base, every institution has its own protocol, but there are certain commonalities. The one commonality is you do acquire thin sections, usually about 3 millimeter slice thickness. You have to acquire in at least two different planes. They are usually axial and coronal, and sometimes sagittal is included. And last but not the least, you do want to get one or two good quality sequences of the whole brain, because the skull base is intimately related to the intracranial cavity. So if you have a tumor that is spreading into the intracranial compartment, as I'm going to show you in a few minutes, there can be lesions at more distant locations, and you will end up missing it unless you have a post-contrast imaging of the whole brain or an axial flare imaging of the whole brain. And with the advent of advanced imaging sequences such as diffusion-weighted imaging and sometimes even perfusion-weighted imaging, we may be able to fine-tune our differential diagnosis. Now let's look at some of the pitfalls that sometimes we face when looking at anterior skull base imaging. Number one is to realize that often different pathologies have similar imaging features. So it's not our goal to provide the final path diagnosis. So lesions such as these, which look superficially similar because they have a component in the nasal cavity and a component in the intracranial compartment, might turn out to be tumors, On the other hand, it might turn out to be something which is a non-tumor. This might be just fungal sinusitis. So the fact is, just the extent and contrast enhancement of lesions is not sufficient to provide a final pathological diagnosis. The second thing is that we need to evaluate the entire intracranial compartment, especially for lesions near the skull base. So this is just an example of a patient who has a olfactory neuroblastoma but has more distant metastasis in the brain. So if you did not include the whole brain imaging, you will miss this, and this is important for planning further therapy. Another thing which you need to remember is that CT and MRI are complementary, so don't jump to a diagnosis based on just one imaging modality. So this is a patient who came to us for potential skull base pathology in the ER, and the resident said this looks like an aneurysm because it does look big here. It's close to the internal carotid artery, so it was dark on T1 and T2 weighted images. But there was some additional imaging that you could have looked at. So if you looked at the CT, you'll realize that this is only asymmetric pneumatization of the anterior clinoid process. So this may not be an aneurysm by itself. So when you have imaging available, both CT and MR, please look at both before you provide your final diagnosis. Now let's move on and look at some of the common pathologies that we face when we look at the anterior skull base. Let's start off with some congenital pathologies. This is a 7-year-old kid who presented with nasal stuffiness. Now the ENT surgeon looked inside the nose and said, I think I see a lesion along the septum more superiorly, so we should get some imaging. And obviously this being a kid, they wanted to get an MRI and not a CT. And this is what the MR shows. There seems to be a T2 hyperintense lesion along the anterior midline nose, and you can track it up almost into the intracranial compartment. And this structure is the crista galli, and this is not a normal crista galli. It looks bifid and unfused in its anterior aspect. So right away you know that things don't look totally normal here. So we should look at it on one more plane. This is a coronal image. Again, this is the lesion. It's easy to miss if you don't know what you're looking for. Thankfully, the surgeons tell us exactly where the location is clinically. And this reaches up to the intracranial compartment, and we do not see any clear-cut intracranial extension. So it seems to stop at the expected location of the foramen cecum. And that's a clue, because lesions associated with the foramen cecum are usually congenital developmental abnormalities. To understand this better, we need to just review a little bit of embryology here. So you have two, or rather three different bones, the frontal, the nasal, and the nasal septum, which are in close proximity but have not fused in the embryo. So there are these gaps. Normally what happens is this dura here, it gets in through the gap, reaches up to the tip of the nose, and then regresses pretty fast. So this is how it should look like in the normal child or adult. Everything is closed, and the dura does not have any outpouching. But things can go wrong. So as it regresses, the opening might remain open here, the foramen cecum, so the portions of the brain or the meninges might herniate, so you have an encephalocele. And even if the dura and the brain retract back, a portion of the dura or brain might get left behind, so you call this a nasal glioma or ectopic brain rest. And occasionally everything might be fine, but a little bit of the skin gets pinched into this tract, and that skin can grow as a dermoid or epidermoid cyst. So going back to the particular patient in question, this is a midline lesion. It does not seem to have a clear-cut communication with the intracranial compartment. So this could be like an ectopic brain rest or a dermoid cyst. Dermoids typically have a little bit more fat. So we said this could be either, and when the surgeon took it out, this turned out to be a dermoid cyst. And the only reason they took it out in this particular instance was they thought it might grow and cause more nasal stuffiness. Typically they just let these lesions be. This is another example in a different patient where the foramen cecum has remained open, and you can see brain herniating through the defect. So this is the classical encephalocele. Let's look at a few more pathologies involving the anterior skull base. Let's start with some inflammatory and infectious pathologies. This is a 32-year-old lady presenting with proptosis, and one look at the CT and you realize why there is proptosis. There is an abnormality which is pushing on the right-sided orbit and pushing the globe outside. And this abnormality looks low in density on CT and does seem to have a bony rim or an osseous rim and can be tracked into the ethmoidal sinus. So it seems to be arising from the ethmoidal sinus and projecting more laterally. You look at it in a slightly different plane, you see that this is definitely connected to the ethmoidal sinus and is showing some degree of osseous erosion. So the fact that you don't see the bone here does not mean it is automatically an aggressive lesion. When slow-growing lesions grow over a long period of time, they tend to thin out the bone. So the bone may not be very easily appreciated. The bone might actually be present, but it might be so paper thin that you can't see it on CT. And this does not have any frankly aggressive features, but this is the classical appearance of a mucocele. But when you identify an entity as a mucocele, you don't stop there. You want to find out what is the cause of the mucocele. So in a good proportion of cases, there is an obstructive cause, and that obstructive cause can be neoplastic. So it's our goal to try and go back and look at the imaging to figure out is there is a small tumor at the drainage pathway. So once you identify a mucocele, you have to look for the inciting cause. In this particular patient, there was no inciting cause. It was thought to be due to chronic inflammation. This is another patient who had a long-standing presentation of nasal obstruction and proptosis for 4 years. And she's quite young, and the lesion looks very aggressive just on superficial analysis. It looks like it's blown through the nasal cavity into the intracranial compartment. There are huge components in the superior portion here. But if you look at the MR in detail, there are some clues as to what this could be. So this is how it looks like on post-contrast MR. Again, looks very aggressive because you have extension across the skull base into the intracranial cavity. But if you look at the T1 and T2 weighted pre-contrast images, it's showing that there is T1 hyperintensity on pre-contrast imaging, and it's in fact so dark on T2 weighted imaging that you could mistake it for air. So if I just showed you the T2 weighted images, it just looks like there is some expansion of the sinuses by air, and that's a clue. This is classical allergic fungal sinusitis. Now, the fungal elements, along with a lot of inspissated secretions, reduce the T2 signal to that extent that it starts looking like air. The other clue that this is not probably a malignant neoplasm is the fact that all of these intersinus septations are very well preserved. Malignancies will typically destroy these intersinus septations. They will not preserve it or even thicken it like this. So that's an important clue. And the third clue was the long-standing history, the 4-year history. So putting all of this together, you can look like a star and say, I think this is allergic fungal sinusitis. Now, it's important to know that it's not just one particular type of fungus that actually causes this. There can be various types of fungi that actually result in this type of allergic reaction. But you can have clues on imaging to making the diagnosis. This is another patient who shows expansion of what looks like portions of the frontal sinuses. In fact, in some locations, you don't even see the bony or osseous rim posteriorly. Again, the history is long-standing nasal obstruction. The intersinus septations are preserved. So it's starting to look more and more like maybe this is also another patient with allergic fungal sinusitis, but this turns out to be a patient with sinonasal polyposis. If you do an MRI in these patients, the typical polyposis patients will show increased signal on T2 weighted images, unlike the allergic fungal sinusitis patients who will show decreased T2 signal. So that is one way of making the distinction. Now, we've seen some inflammatory pathologies and some infectious pathologies. We also tend to see a lot of tumors involving these regions. So let's look at some tumors and tumor mimics. So we'll divide it into 3 major locations. Tumors which arise just below the skull base, tumors which involve the skull base primarily, and tumors which arise above the skull base and then involve the skull base. So if you start from below, this is a patient who has presented with fatigue and Cushing syndrome, a short history. And on the first imaging the patient ever has, this is what we see. We see a mass involving the nasal cavity, ethmoidal sinuses, has an intracranial extension. The first thing to do, look for the intersinus septations. There are no intersinus septations. They've all been destroyed. So this tells you you're probably not dealing with something like allergic fungal sinusitis. This looks more like a malignant neoplasm. Now, you look at it in other planes, you can clearly see the intracranial extension. You see significant contrast enhancement as well. At this point in time, it's very difficult to predict what the final pathology is. So if you say it looks like a malignant neoplasm and describe its extent, that's probably sufficient because it's easy to get tissue diagnosis by putting in an endoscope or even just looking directly and taking some tissue out. This patient also happened to have an octreotide scan which lit up like this and ended up with an esthesioneuroblastoma. Now, it's easier to predict a lesion is esthesioneuroblastoma if you find a lesion localized to the roof of the nasal cavity, because that's where they typically arise. But once a lesion gets this big, like in this particular patient, the final tissue diagnosis is actually difficult to make. And esthesioneuroblastoma tends to be very similar to other neural crest tumors. There are some clues on imaging though. So if you have a lesion which shows a lot of homogeneous enhancement and shows this peripheral cystic interface where it touches the brain. That's one clue that you might be dealing with an esthesioneuroblastoma. It is not 100% specific, but is a reasonably specific finding. And in esthesioneuroblastoma, it's important to know that there can be dural spread. So this patient had recurrence of an olfactory neuroblastoma right here where the primary site was. And when we did whole brain imaging, we can see many areas where the dura is thickened, nodular, and enhancing. So the cutoff point generally used is it at least 5 millimeters of dural thickening, or does it show significant nodularity? Because often where the lesion touches the dura here, they can be just reactive dural thickening. So you need to look for something which looks quite nodular and at least 5 millimeters in thickness to say this is likely dural metastatic disease. Let's look at another patient where we see a lesion which has destroyed a lot of the normal anatomical structures. It's invaded into the orbit, and this turns out to be squamous cell carcinoma. This could have been an esthesioneuroblastoma. So the point I'm trying to make is it's very difficult to make a final path diagnosis just based on the enhancement pattern and the extent of the lesion. This is another patient showing a very aggressive appearing process, dark on T2, shows some degree of contrast enhancement, and this turns out to be sinonasal undifferentiated carcinoma. So again, reiterating the important fact, it may not be possible for you to provide a final path diagnosis, but it is important for you to tell the clinician what is the extent. So extent into the intracranial compartment, extent into the orbits. The other important information that you definitely need to convey to the clinician is there spread along the important cranial nerves? So this is a patient who has a primary skin cancer over the forehead, and there was no clear extension into the orbit except in the form of this subtle finding. So let's look at the anatomy in a little bit detail. So this is the superior rectus complex on the right side, and the enhancing structure just below is the superior ophthalmic vein. On the left side, you see the same superior rectus, the superior ophthalmic vein, but on top of the superior rectus complex, there is an additional nodular structure, and you can track it posteriorly as well. This is where we expect the ophthalmic division of the fifth cranial nerve to be. So this is perineural spread along V1 cranial nerve, and this is important to pick up because it will not come to light for a few months, and it is up to us to try and detect this type of perineural spread. Now moving on to tumors involving the skull base by itself, obviously because it is made of bone, we are going to talk about osseous or fibro-osseous lesions, and the classical entity you are likely to encounter is fibrous dysplasia. It has a typical ground glass type of appearance, expansile. It can appear very aggressive on MRI. So if you find something which is heterogeneous on T1 and T2 signal, enhances a lot, but seems to be primarily involving the bone on MR, please get a CT to correlate because CT will provide the final diagnosis. When you do have a patient with known fibrous dysplasia, you have to ask about the presence of any new symptoms such as pain within the region. You also have to look on imaging for new lytic areas because that is a bad portender of malignant degeneration. So fibrous dysplasia, while it is benign, can degenerate into fibrosarcoma or osteosarcoma. So when you do serial imaging, this is what you need to look for, not just the presence of fibrous dysplasia. Are there any new lytic or sometimes sclerotic areas? And when you discuss a patient with fibrous dysplasia in your report, it's not sufficient to say this is fibrous dysplasia, end of case. If it is encroaching on important neurovascular foramina, you have to put it in your report. Is it encroaching on the optic canal? Is it involving some of the major foramina in the skull base? Because that's very pertinent for their symptoms. When you move to tumors arising above the level of the anterior skull base, the typical one we will encounter is a meningioma, which can sit right on top of the planum sphenoidale. It's easier to appreciate once you give contrast. It might be very subtle on T2-weighted images like this. It is rare, but sometimes these tumors can extend through the cribriform plate downwards, just like tumors in the nasal cavity can go upwards. But it is a rare finding. What you're more likely to see is thickening of the bone adjacent to the meningioma because of hyperostotic reaction. This is another patient with a large meningioma. There was very, very minimal thickening of the osseous structures. But if there is, you need to put it in your report because this will be followed up over time. The last type of pathology which I will briefly touch upon is CSF rhinorrhea. So this talk is not focused on it, but I want to give you a few take-home points. So this can occur either in the traumatic setting or as a spontaneous CSF leak through the nose. The first thing to do when you suspect CSF rhinorrhea is not take the patient to CT or MR. You have to test the fluid. It has to be positive. So if the fluid is positive, it's only then you actually take the patient for a cross-sectional imaging. And you typically test for beta transferrin, and if that's positive, then you move on to cross-sectional imaging. When you go to cross-sectional imaging, it's important to remember that the anterior skull base has a lot of structures which are so paper thin. So two areas through which typical CSF leak occurs are the horizontal portion of the cribriform plate and the vertical portion, which is called the lateral lamella. And these structures might be difficult to appreciate on CT imaging, especially if there is no contrast on the other side in the CSF spaces. So getting a simple non-contrast thin CT is good for large osseous defects, but it is not predictive that there is definitely a CSF leak occurring through that thin bone. You probably can do a CT cystonogram where we inject contrast into the thecal sac, run it into the intracranial compartment, and wait for that to leak into the nose. So different institutions do it in different ways. We try to do it prone imaging at our institution, trying to see if there is going to be more leak when the patient is put in a prone position. There are some institutions which also try and look for these leaks by doing thin, heavily T2-weighted sequences such as a Fiesta sequence. And all of these, in my opinion, provide some degree of complementary information. And this is a patient who has a clear nasal discharge which tested positive for presence of CSF. When we did a CT cystonogram, you can see that there is contrast which is leaking out into the top of the nasal cavity. And this is leakage into the cribriform plate. One word of caution here is that sometimes discharge, which is along the superior aspect of the nasal cavity, can look bright. So at our institution, we tend to obtain a non-contrast image to compare with. Otherwise, you do not know if this is truly iodinated contrast or not. And this patient actually had another defect in the top of the sphenoidal bone and a lot of contrast pooling in the sphenoidal sinus. So this teaches us one more important aspect of CSF leak. It can be multifocal. So the fact that you find it in one place does not mean there cannot be more osseous defects. So in summary, the anterior skull base anatomy can look a little bit complex. But if you have a systematic approach and try and determine, is the lesion looking more along the benign end of the spectrum, malignant end of the spectrum? What is its intracranial extension? What is its orbital extension? Is there any potential perineural spread? Then it's possible to provide a reasonable differential diagnosis. And also, CT and MRI are complementary, with MR providing the bulk of the tissue characterization. Thank you very much for your attention. Now Dr. Wiggins will take over and talk about, I think, central skull base.
I will now take over. Consider yourselves taken. You're not going to let me drink your coffee? So I'm going to talk about the central skull base. So we'll look at anatomy and some imaging pearls and pitfalls of this area. I have nothing significant to disclose to you. I don't own the central skull base. My family does not invest in it. I don't make any money if you image the central skull base. I have nothing. So we're going to look at anatomy and pathology and discuss some of the areas around here. And similar to the other talks, we'll look at all this anatomy in different ways. So we'll look at the anatomy and then look at pathology. And I'm going to focus on that central skull base part in the middle, and we'll look at the anatomy first. So as you just heard, we have kind of the anterior skull base. I'm going to talk about the central in this area, and then next we're going to talk about the posterior skull base. And we can think about the skull base as these different areas, anterior cranial fossa, middle, and posterior cranial fossa, or we can think about it kind of as the individual bones that are there with the paired frontal, parietal, temporal bones, and the unpaired ethmoid, sphenoid, and occipital bone. So I'm looking at this part right here in the middle, the central skull base, and it's mostly that sphenoid bone right in the middle of that area. So when we think about this complex anatomy in this area, there's a whole bunch of cranial nerves in this area. And as you heard, we can have stuff from above go down to the bone, and we can have stuff from below go up into the bone to involve them. So the central skull base is the part that's posterior to that lesser wing of the sphenoid and the planum sphenoidale, and anterior to the petrous ridge and the temporal bone kind of in the back. So we have this anatomy. So up here is that anterior skull base. So we have stuff, as you just heard, from the orbit or from the nose that goes up. And here in the central skull base, we have all these cranial nerves that are in this area. And it's really dominated by the fifth cranial nerve and its big divisions going over. So here's a sagittal graphic and a sagittal T2 weighted MR. So we think about that central skull base of the midline, that sphenoid bone, and various aeration of the sphenoid sinus as it goes down into it, immediately under the pituitary gland. So we have the pituitary and the infundibulum above, and we have the nasopharyngeal mucosal surface immediately below that central skull base. And we can see here on imaging, as you heard, we can have fat in here, so it may be very bright on T1. And if we have aeration of that sphenoid sinus, it may be dark on all of our sequences on MR. So we have some important anatomy around that area. There's a break between the lesser wing and the greater wing of the sphenoid. That's a supraorbital fissure. So all the stuff going to the eyeball here, V1, 3, 4, and 6 are going through that. We have lower a fissure that's between the greater wing and the maxilla. That's the infraorbital fissure. We have the internal carotid artery more inferiorly and posteriorly. And foramen rotundum, as you heard, this is a view in the axial section, so round in the coronal plane, as you just heard in the prior talk. This is foramen rotundum where V2 is going through. And here we have the high-heeled footprint of the skull base. This is foramen ovale. So ovale right here and spinosum immediately behind it. So the oval part of the footprint is ovale and the spine of the shoe is spinosum. Does it look like a high-heeled? Here, let me help you. So there's this high-heel. There's this great shop straight down where you can get these in a size, but never mind. But that's the high-heeled footprint there of the skull base. And we can find the medial portion of the condylar head. And if you go about a centimeter forward and a centimeter medial, that's where ovale is if you ever try to find that in V3. So as you heard, we have CT and MRI. These are both complementary in this area. We do CT to look for the bones. We do MRI to look for the soft tissues. We give contrast to look for enhancement, especially with peritoneal tumor spread. When we look at an MRI of the skull base, just like the extracranial head and neck, for us sometimes the pre-contrasted T1 is more important than the post-contrasted. For everything in the extracranial head and neck, where there is air and where there is fat is very important for a lot of our pathologies. So when we have a pathology that's replacing the normal fat at that location, that's very important for us. So here's a pre-contrasted T1. I look at the nose and it's dark, so I know it's pre-contrasted. Just as we mentioned, here's that condylar head. If I find the medial part goes centimeter medial and a centimeter forward, then I see V3 right there coming down under ovale. And I think about the central skull base pathology on pre-contrasted T1, because where there's bright fat and where there is replacement of that bright fat is very important for a lot of these pathologies. So it's dominated there by the fifth cranial nerve as it comes out. So here's our fifth cranial nerve. So we have our pons here in the medulla. We have 3 sensory nuclei that contribute to 5. There's one little motor that's all going down with V3. So we have, just like the other cranial nerves, we have an intraaxial segment, part in the prepontine cistern, the semilunar ganglion, and then the divisions V1, V2, and V3 coming off. So we have 3 sensory nuclei. There's one going up towards the midbrain or the mesencephalon, so that's the mesencephalic nucleus. There's one big one, that's the main sensory, and there's one that goes down in the spine, so that's the spinal nucleus. And then we have one motor that all contributes to it. So if we put out our hand and kind of put our thumb down, and then you tuck in your pinky and your ring finger, that's the fifth cranial nerve for you. So imagine me belly is the pons, and we have the prepontine segment coming out. V3 is going to be your thumb going down through ovale, and V1 and 2 are going forward into the cavernous sinus. So that's the fifth cranial nerve gang sign. Yo. So we can remember that anatomy as it goes through, and this is a big part of the central skull base, especially as you heard when we were talking about peritoneal tumor spread. So here's that thin curvilinear Vidian canal coming out, going forward to the pterygopalatine fossa, and that's an important way station for us in the deep face, especially with peritoneal tumor spread. We have all these structures around there that are named on where they go. So there's a foramen kind of between the sphenoid going down towards the palate, so that's sphenopalatine foramen. There's a fissure out laterally between the pterygoid and the maxilla, so that's the pterygomaxillary fissure. And this is an important connection as a way station to the deep face, especially with perineural tumor spread. So that's a very basic anatomy kind of around that area, and we'll finish up the rest of our time looking at the pathology. When we think about pathology here, especially on CT, we want to be very careful about the words we use when we look at these pathologies. A lot of them look very similar. So if something is expansile, destructive, permeative, sclerotic, it may suddenly send us on a completely different differential. And we'll hear about that a little bit more in our next talk. But in the central skull base, it can be very confusing. So we want to be very careful about the words we use to describe osseous changes. And we want to remember the anatomy that's around these structures and see how the pathology affects that anatomy. And it helps us sometimes guess the pathology based solely on imaging. So we have intrinsic and extrinsic things here. We have things that arise from within the bone, and we have things that are from the outside. And it can be very confusing. And just like in the superhyoid neck, we think about all these fascia layers that define spaces. We don't want to just say there's a mass in the deep space and then give a huge differential of things. We want to try to think about the pathology that happens to this anatomy and make a better differential than just listing a whole bunch of things. And that frequently happens, and it happened at my shop recently with a case. So we had this unknown case come in, and they did a CT of it, and we see this large mass just kind of destroying the central skull base. It's hard to see much of anything there. So they did an MR. So here's the AX-T1 pre-contrasted, and not very exciting, but we see the mass there. So they gave contrast, and we see that the lesion is enhancing itself. We did a T2. Well, it's kind of dark on T2, and we can roughly use T2 as kind of a marker of tumor cellularity. So hypercellular things are dark on there. And here's a sagittal T1. So we had this study as an unknown skull base lesion. So a whole bunch of different things that we could do, but we want to try to evaluate all these images very closely, think about where the center of the lesion is and how it affects that anatomy around the area. So they had this study, and what did they do with it? Well, they generated a report. And, you know, that's really our big communication with the referring docs. We want to get as much clinical information as we possibly can from them. But when we give our information back to them, we want to think about exactly what we're saying and be very concise about this. And this is the actual report that those guys put together on this. I say those guys. It's in my shop. It's my friends. They're colleagues. I respect them very much. But this is the report. It just kind of went on and went through a whole bunch of different things. It was a long, long report. And the important part, obviously, of the report is the impression. A lot of times the referring docs are only going to read that impression. If they don't understand it, then they go back and read the body of the report. But you want that impression to kind of be a one-liner. And when I look at this impression, there's a whole bunch of things that are kind of the differential of what they thought about. And if I just look at that list of all the differential considerations, it's kind of like everything that was in there. Now, I kind of blame myself when I saw that my fellow had done this, because I had just given a talk about the skull base a couple days before, and I knew he had those slides. And I noticed that his impression looked a whole lot like this. So in some ways, I kind of had myself to blame. But he showed me the case, and I looked at it, and I looked at the CT, and I looked at the MR, and I told him what I thought it was. And he told me later, he said, oh, you know that case I showed you last week? You know, they did a biopsy, and you were right about it. And I was cool about it. I said, oh, really? Well, even a blind squirrel gets a nut every once in a while. But we're going to look at all these pathologies and go through some of them, see how they're similar, how they're different, and how we can differentiate between these. So just like you just heard, in the anterior skull base, we've got stuff from the eyeball and the nose that could go up into the anterior skull base. We also have the sphenoid sinuses that can go back here. So I put a correlating case in for his. This is a central skull base pitfall. It's the sphenoid sinus disease in this area. So here's an MR this patient had done, and they had a little area of ischemia, they thought, back here. And this is a contrasted MR. And they did a CTA to try to figure out the blood vessels because he's got areas of ischemia. And they thought there was this little thing up here that might be an aneurysm. They did the pretty 3D recons. Yeah, it looks like it. Okay, good. So they went and did an angio to confirm. Yep, looks like an aneurysm. And, yeah. So we have neurosurgeons at our hospital. So they decided that they should go and clip this aneurysm. So they go in there and they put a clip on it. And unfortunately, they said later, well, we went in, and as soon as we went in to put the clip on it, the whole blood vessel just kind of fell apart. It was all this friable tissue. It was just really, and they ended up with kind of a bad result of the whole thing. And this patient, unfortunately, passed away afterwards. But this is a case where somebody showed me later and said, oh, we had this horrible case. We showed a QA. And as soon as they pulled it up and showed it to me, I said, well, what's going on in the sphenoid sinus? And this is one of those cases where you have the stack, and the first image that comes up is number 1 around the skull base. So the very first image came up, and I said, well, what's going on in the sphenoid? And they all went, oh, well. So just like that case you saw earlier, it can be very dark on T2. It's like Sesame Street. One of these things is not like the others. This sinus is not like the other ones. It's very bright on T1. There's only about 6 things that are bright on T1, like fat, gadolinium effect, melanin, proteinaceous stuff. So you have to put it in one of those categories. If you do a fat set and it stays bright, it's not fat. If you haven't given contrast yet, you know it's not contrast effects. This is very dark on T2. They gave this guy contrast, and the mucosal surface of this sinus is not enhancing like the other ones are. And unfortunately, what they didn't notice was, just a little while before, that was normally aerated. What happened to this guy? Theoretically, we all walk around breathing in, 50 million spores of fungus a day, depending on where you live on the fungus belt. Most of us are perfectly fine with it, but every now and then we get fungal disease. That can invade the surrounding structures, and in this case, it went from the sphenoid out into the cavernous sinuses. So it was really kind of a mycotic aneurysm of fungal origin. Sinus disease can kill you. So unfortunately, this was read out as there's some sphenoid sinus disease. It was kind of buried in the body of the report. It wasn't mentioned in the repression. But if you have an air cell that's completely opacified, as you just heard in the prior talk, you need to explain that. Go look closely and figure out if there's a lesion obstructing it. So other pathology we have. You heard about fibrous dysplasia. Here we're looking for that expansile change to the bone and the ground glass that's around it. So here's another case as you saw earlier. And here's rotundum and vidian that we saw it. And here we see they're very narrowed at that. We see that ground glass and expansile changes. So we can have fibroosseous lesions of the skull base. Around the face, we have a whole bunch of things that can happen to the bones. Ossifying fibroma, non-ossifying fibroma, fibrous, a whole bunch of different pathologies. If we do an MR first, it can be really confusing, as you heard earlier, because it looks like a much more aggressive kind of pathology. So here's a T1 pre and post kind of swirling mass at this location, heterogeneous enhancement. And we looked at the diffusion in the ADC, and it looked kind of like high ADC values. We measured it, and it was very high. So we can measure the ADC values and use the ADC also as a rough marker of tumor cellularity, and things that are not very cellular are more likely to be benign, and things that are very hypercellular are more likely to be malignant, and they're much likely to be lower values. So if we use 1 as a cutoff, this is at 1.63. This is much higher than that, so we're thinking a more benign entity. And that turned out to be a fibrous dysplasia case with the ground glass changes around there. So we can see sclerotic changes, can be cystic, can have a lot of different changes, but the expansile ground glass nature is what we look for. One pearl around here, if we have stuff that extends from the central skull base out laterally towards the temporal bone, is Paget's disease. We try to differentiate that from fibrous dysplasia. Theoretically, Paget's has the expansile cotton wool, whereas fibrous dysplasia has the ground glass. One interesting thing about the otic capsule, the dense bone that's around the inner ear structures, Paget's causes this osteoclastic reaction that goes right up to the otic capsule and through it, whereas fibrous dysplasia has relative preservation of the otic capsule. So that's a good pearl for us in the central skull base to try to differentiate those two pathologies if they're similar, and we can't quite tell if it's cotton wool or if it's ground glass. So METs, if we have a marrow replacing process of the central skull base, and again, anytime we have clinical history is going to deviate us from one way or another. So any marrow replacing process, we think about METs, myeloma, lymphoma, leukemia, plasmacytoma, anything like that that is, can replace the normal fat that's in the skull base. So if a patient has a known malignant lesion, and we see something like this axial T1 pre-contrasted study, where we're replacing that normal marrow, we're going to think about a metastatic focus at that site. If they have a history of lymphoma, we're thinking about that. If they have a history of EG, we're thinking about that, LCH. We see destructive changes on the CT. So here, just at the front of the Vidian canal and the back of the pterygopalatine fossa, we have a soft tissue mass with permeative destructive changes of the bones. And we give contrast, and we see correlating enhancement in that same area. If I know this patient has a known primary and metastatic disease in other locations, yeah, I'm going to think this is probably a metastatic focus. Now, meningiomas, as you heard, can have different appearances. Most common extraaxial tumor, usually dural base with dural tails, avid enhancement, but they can be intraosseous. So what we like to see is extraaxial mass with avid enhancement, dural tails, and a dural base. They extend through all those foramen around the central skull base when they occur there, but we can also see meningiomas within the bone. So again, just like a marrow replacing process, this is going to be a big differential, and it's hard to differentiate sometimes those pathologies. So here we see an avidly enhancing mass of the central skull base of the sphenoid. They can also be intraosseous. Here we have a bone algorithm. We see this lateral wing of the sphenoid, and this more aggressive kind of a periosteal change. So, we're thinking a much more aggressive thing. Is this a telangiectatic osteosarc? This is something really bad. But we look at the soft tissues that are around it, and we see the soft tissues are very benign. And this is a great location for an intraosseous meningioma, that lateral sphenoid wing or lateral wall of the orbit. But we can have this sunburst appearance for the bones, so it can look very aggressive. Multiple myeloma, again, if we have the history, then we're going to think about that pathology in this area. We have multiple lesions, so instead of the normal foramen, we have all these extra foramen around the central skull base, all these lytic lesions around. So if the patient has multiple myeloma, that's a good appearance for this on CT, where we see a whole bunch of what looks like extra foramen. And if we do a solid mass and we do an MR, we may have a dark on T2 lesion with multiple myeloma patients if they have a plasmacytoma. So again, the T2 is a rough marker of tumor cellularity. Things are going to be dark. So next is lymphoma, another big mimicker. It can look a lot like different pathologies. So again, the more clinical information we have, the more likely we are to say something in our report that's going to be helpful to our referring docs. So we can have lymphoma that's primarily within the bone or originating from the dura. It can have a lot of different appearances. So here's an axial CT, and at the central skull base of the clivus, we have this marrow replacing process that's destroying the bone and extending out towards the orbit in those different canals. So if I know this patient has history of lymphoma, that's what I'm going to be thinking of. They can also involve the bone. So here's a very similar case to those earlier studies. It looks a lot like that meningioma, looks kind of like the plasmacytoma. But if I look at it, we have relatively benign soft tissue that's extending out laterally into the cavernous sinuses from that central skull base. It's going back towards the prepontine cistern. And we see all those changes here on this axial post-contrasted MR. If I know the patient has a history of lymphoma, that's what I'm guessing this is. Lymphoma, interestingly, is one of those things that has very low ADC values. It's one of those hypercellular things. So it may have ADC values that are even lower than squamous cell carcinoma, can be lower than 0.7. So here's a case we had recently, very similar to that intraosseous meningioma that we just looked at, relatively dark here on the T2, and we did a T1, not really bright on T1, little change in the bone around it, and when we give contrast, we see relatively benign soft tissues around it, and we looked at a diffusion and an ADC, and it gave us very low values. It was 0.5. So another rough marker of tumor cellularity is those ADC values. We want to be careful how we measure it. You don't want to include the outside 2 or 3 millimeters of the lesion. If the lesion is a big cystic area, you don't want to measure right where the cyst is. That's going to give you false values. But as a central skull-based pearl, we can think about those ADC values to help us differentiate these pathologies. So next we have nasopharyngeal carcinoma. If we have a tumor of the pharyngeomucosal surface of the nasopharynx, it can go up into the central skull base. It can go directly into the bone. It can get on one of those nerves and crawl along that. Or we have these vessels, the artery and vein, so it can crawl along those vessels to get into cranially. So here's a case with post-contrasted MR at T1, and we see enhancement over here and enhancement of the central skull base. And this was a nasopharyngeal carcinoma that decided to just go straight into the bone immediately superiorly. Here's another case, axial T1 pre-contrasted. We see a large mass of the nasopharynx, and you see how it went out laterally and started encasing and surrounding the carotid, and it just crawled right along the carotid. So this is kind of perivascular spread. We talk about perineural tumor spread, but you can have perivascular, perifascial, periosseous, peridural, any kind of spread. So this is a tumor that got along the artery and was just crawling up the artery through the horizontal segment and then into the central skull base. Next we have macroadenoma. So normally with a macroadenoma, path of least resistance is going to be up, soft squishy brain, not down into the central skull base. So normally we look for a nice snowman shape of a lesion there at the sella turcica, the Turkish saddle, where the pituitary normally lives. And we see it extending up, and we think about that diaphragma sella that's supposed to be intact over it. So even if it's pushing that optic chiasm way up high, they can still go transsphenoidal and suck out everything and pull it all down because that diaphragma sella is supposed to be intact. But sometimes they go out laterally into the cavernous sinus. So then we're looking at the carotid flow void, and we're trying to figure out, is this more than 180 degrees around the carotid to try to help differentiate, is the tumor invading the cavernous sinus or not? These valveless venous sinusoids that are on both sides of the pituitary gland. But we can have a pituitary macroadenoma that decides to go down. We can have aggressive ones that extend down inferiorly and directly into the bone. So here's a case. Again, we have a lesion destroying the central skull base, not really specific of anything, but this, where we try to find out, is this separate from the pituitary, and is it separate from the nasopharyngeal tissues below? So here's a graphic showing a pituitary macroadenoma that was invasive and aggressive and went down into the central skull base. And here's an actual case. So when I see a central skull base pathology, I look at my sagittal images and I try to figure out, is there a normal pituitary up above this thing, and is the nasopharyngeal mucosal surface normal below it? Because I can have lymphoma or a nasopharyngeal carcinoma going up, and I can have a pituitary macroadenoma that goes down. So here's another case where we have a mass destroying that central skull base and extending up not only in the sella and suprasellar, but down into the central skull base and the sphenoid. And I'm trying to figure out, is there a normal pituitary gland separate from this thing? So I'm going to mention briefly chordoma and chondrosarc. You're going to hear more in the next lecture. But a chordoma is going to be a destructive lesion of the central skull base and has bright T2 signal. So here's a graphic showing that. Now I have a normal pituitary gland, but I have a large mass that goes back and thumbs the pons. It's very bright on T2 and expansile at that location. So if I do have a lesion there at the central skull base and I see normal nasopharyngeal tissues below and I see a normal pituitary above, I may be thinking about this pathology, especially if it goes back and thumbs the pons like this. And then it may have heterogeneous enhancement in that area, but I can still see a normal pituitary above it. So that's another good pearl for us. If I have a lesion that's in the central skull base, but I see no normal pituitary, that may be a macroadenoma. If I see a mass destroying it, but I do see a normal pituitary above, I know it's not a pituitary macroadenoma. So that helps me with the differential there. And then briefly, chondrosarc, another expansile lesion that's bright on T2, usually off midline at the sutures. So here's a graphic showing something that's centered off midline at that location. And it's also bright on the T2 and avidly enhances. So that's another kind of differential for us with the chordoma. We talk about half of these having the chondroid matrix within it. Those are actually numbers we kind of stole from the spine guys. We take the numbers that they were described in the spine literature and apply it to chondrosarcs in the skull base, if chondrosarcs show up in the larynx or anywhere else. But this is that chondroid matrix we might see within it. So if we have a bright lesion of the central skull base, we want to try to differentiate a chondrosarc from a chordoma. Both expansile, both bright on the T2, both may go back and kind of thumb the pons and the brain posteriorly behind it. But the center of the lesion is very different in the center of the skull base, or is it out laterally if it's arising up here in around the sphenoid. So we have all these pathologies, and we want to be very careful about the words we use: expansile, destructive, permeative, sclerotic, because as soon as we say one of those words, it may lead us down a different path. But we want to look carefully at both the CT and the MR findings. As you heard in the earlier talk, those two studies are complementary. We use them both, and we want to pay attention to how both those imaging pathologies affect the normal anatomy. So here's that case that we had before. They showed me this case, and I looked at it, and I said, I think it's probably this. And they told me later that it was. So this is the report that it was. They had this big differential. So I sat down and I looked at their differential, looked at the imaging, and kind of walked through with them why it is or is not kind of all of these things. Now, when I look at this differential and I look at the pathology they had, I can see a normal pituitary above this thing, so I'm guessing it's not that. When I look down at the nasopharynx, the nasopharyngeal tissues look fine. So I don't think it's a nasopharyngeal carcinoma or a lymphoma coming from the upper digestive tract invading the bone. Now, when I scooted that over and looked at the T2, I see that on the T2, this thing is very dark. It's not bright, so I can probably scratch off chordoma and chondrosarcoma from that list. And they actually measured ADC on this value. It's actually pretty low. So I'm thinking about a hypercellular thing using those ADC values as a rough marker of tumor cellularity. So, you know, maybe not EG or histiocytosis. We're thinking about some of those other aggressive pathologies. And they actually had a CT. And they did the CT and the MR, so both things. And this is an area where we don't feel bad about recommending the other modality when we already have one, because they are complementary, and we know it's going to help them with their surgical approach and taking care of the patient. And when I zoomed this up and kind of looked closely at this, I saw that there were all these other punched out lesions on the study. So because of that, I looked at it and I said, well, I think this is probably a patient with multiple myeloma and this is a plasmacytoma. And they showed me the case a week or so later and they said, oh, you were right about that. And I was cool about it. I said, oh, well, really? Well, you know, I guess every now and then you get something, right? But this is an area where if you think about the imaging characteristics, think about the pathology that's there, think about the normal anatomy, we can sometimes come up with the right diagnosis based solely on the imaging. So when we think about the central skull base in this little area right here, it's a relatively small area compared to the anterior skull base and the posterior skull base, but it's extremely complex. Remember, we have the fifth nerve going through there. Remember your fifth nerve gang sign, especially with perineural tumor spread if you think there's pathology around that location. So we want to get as much clinical information as we can. Anytime we have a head and neck study, that clinical information completely changes the way we read out our reports. If I'm doing a soft tissue neck and the guy's had surgery, chemo, XRT, and a tumor, or none of the above, I may read it out completely differently. So if we're reading studies without clinical information, you can be dangerous, actually. Remember all these fibroosseous lesions, ossifying fibroma, non-ossifying fibroma, fibrous dysplasia, Paget's, and think about how they change the bone. And be careful about the words you use when you're describing things. Lytic, expansile, destructive, permeative, sclerotic. As soon as you start using some of those words, it sometimes may lead you down a completely wrong path if you're talking about them incorrectly. So remember to look above and look below. Anytime I have a central skull base lesion, is there normal pituitary gland above and is there normal nasopharyngeal mucosal surface below? Think about where the center of the lesion is. Is it centered at the midline? Is it centered off midline? And sometimes it's hard to tell, especially when these pathologies get big. But we always want to try to remember the normal anatomy around the central skull base and see how the imaging pathology affects that anatomy. And then lastly, remember those cranial nerves. And we talk about perineural tumor spread a lot, but you can have all kinds of other tumor spread, perifascial, perivascular, periveneal, and anything around that area. So that's some anatomy pearls and pitfalls around the central skull base, and I thank you very much for your attention. So our next speaker, Dr. Tabitha Kennedy from Wisconsin, is going to continue the discussion now with the posterior skull base.
Thanks, Rick. He's a really tough act to follow, right? So for the next 30 minutes, I'm going to be talking about the posterior skull base, and you're going to see that there is some overlap between our talks. But redundancy is a key. So I have no disclosures, and I want to I've got a couple of acknowledgments. I'd like to thank Greg Avey, who's one of my colleagues at UW, and then Justin Brucker, who's one of my superstar fellows, who's given, both of them have given me a lot of cases for the talk today. So I have three primary objectives, and essentially by the end of the talk, you should be able to identify the relevant anatomy of the posterior skull base, categorize pathology based on anatomic location, and then be able to generate a short differential based on anatomic location. So of course, as radiologists, we want to make the diagnosis, right? We always really generally want to be correct. And so to be able to do that, we need to be able to tailor and generate a really concise and thoughtful imaging differential diagnosis. And to be able to do that, we really have to be able to first recognize that there's an abnormality, localize the lesion, and then characterize the abnormality, as Rick has just mentioned in his talk. And then to be able to do that, we actually have to do the appropriate imaging test, and that all stems from the clinical differential diagnosis. So having really good clinical history can really help us ultimately make the diagnosis. So in terms of the posterior skull base, we have patients can come to our imaging attention via a number of different pathways. We could be screening for metastasis. The patient could be presenting with a headache. They could have a specific cranial nerve palsy that involves a single cranial nerve or potentially multiple cranial nerves, or we could actually just be seeing an incidental finding. So we're going to be looking at a number of different kinds of studies. So the patient could potentially get a brain MR without and with contrast. They could potentially get a neck CT looking at some of these terminal branches of the cranial nerves, or potentially an MR with a cranial nerve protocol with those high-resolution images that we would be looking specifically at those cranial nerves, or potentially that incidental finding that you could potentially see on a CT of the cervical spine, a sinus CT, etc. So in terms of the anatomy, the posterior skull base here, we can see it cradles the cerebellum as well as the brainstem. So the brainstem, obviously we've got the medulla, the pons, and the midbrain, and from those different parts of the brainstem we have a number of different cranial nerves that exit, and all of these cranial nerves have to exit the skull base via their respective foramina. So we have our cranial nerve 6 that essentially exits along that ventral part of the pons at the pontomedullary junction. We've got cranial nerve 7 and 8 that exit laterally through the internal auditory canal. We've got cranial nerves 9 and 10, 11, as well as 12. So through all of those skull base foramina, these nerves have to communicate with the extracranial compartment or the rest of the body. So now let's take a look at some of this anatomy. And we, of course, have already heard excellent talks on the anterior cranial fossa, the middle cranial fossa. And for our talk, we're really going to be focusing on the posterior cranial fossa. And it's important to recognize that a lot of these spaces can communicate. And so you can see that these bones actually share common walls. And so lesions within the posterior cranial fossa can extend anteriorly, and likewise lesions within the middle cranial fossa and the anterior cranial fossa can extend posteriorly. So in terms of the bony margins that make up the posterior cranial fossa, we can see we've got a very small contribution anteriorly that makes up that superior part of the clivus. And then inferiorly, we've got the occipital bone that essentially makes up that inferior margin of the clivus, and then the rest of that sort of seat of the posterior cranial fossa. And then laterally, we can see we've got the temporal bone. Now, the sutures that essentially separate or connect these these bones together, anteriorly, we've got the spheno-occipital synchondrosis. Laterally, we've got the petro-occipital fissure or synchondrosis, and that continues on as the occipitomastoid suture. Likewise, we've got a number of different neurovascular structures that will enter and exit through the skull base. So we've got our internal carotid artery that is going to pass through the petrous portion of the temporal bone. We've got our dural venous sinus, and then we've got our internal auditory canal that, of course, houses cranial nerve 7 and 8, and then our hypoglossal canal. Now let's look at this 3D reconstruction, and we can see all of those same structures on this sort of slightly obliqued 3D volume rendered image. So we've got our internal auditory canal superiorly, we've got our jugular foramen just below that, and just below that we've got our hypoglossal canal. Now looking from below, we can see we've got our internal carotid artery, our jugular foramen, our stylomastoid foramen, which houses that cranial nerve 7, and from there it's going to ramify into all those branches within the parotid gland. And then just anterior and below the condyle, we've got our hypoglossal canal. So now let's take a look at our coronal view on CT, and we can see all of these same structures on this image. So we can see here our jugular tubercle, and it sort of looks like sort of an eagle, and just below the beak we can see that's the hypoglossal canal. So that's a good landmark to identify the hypoglossal canal. And we can see just above that we've got our jugular foramen, and then just above that is the internal auditory canal. So now, as we've learned in our first two talks, that CT and MR are often very complementary in looking at this pathology. And so looking at the anatomy, it's really important to be familiar with the anatomy both on CT and MR. And on CT, we're going to see the canal, and on the MR, we're going to see the nerve or the structure that passes through that canal. So here, if we're starting inferiorly, we've got our hypoglossal canal. and the nerve that travels through there. And then as we scroll up, we start to see branches of cranial nerve 10 and 11, which are going to go through the pars vascularis portion of the jugular foramen. And just anterior to that, we've got our pars nervosa part of the jugular foramen. And through that, we're going to see cranial nerve 9. As we scroll up even further, we can see cranial nerve 7 and 8 that travel through the internal auditory canal. And then we actually start to see branches, cranial nerve 6 that is along the ventral part of the pons, and that's going to pass through Dorello's canal. And then cranial nerve 5 entering through Meckel's cave. So oftentimes we don't actually get dedicated cranial nerve imaging, but you can see all these cranial nerves just on routine brain MR imaging. And I like to actually take a look at the post-contrast images, and we can see that those cranial nerves are outlined very nicely by our venous sinuses. And so if we start actually from above, we can see at the level of the inferior petrosal sinus, as we scroll down, we are outlining cranial nerve 9 that is essentially going to travel with the inferior petrosal sinus outward. As we scroll down even further, we can see, now we start to see branches, our cranial nerve 10 and 11, and then our cranial nerve 12. And so we can actually see these nerves on routine imaging if you just take a look. So when we talk about skull-base pathology, it's good to have a general approach on how to essentially come up with a reasonable differential diagnosis. So we can talk about diffuse lesions or multifocal lesions that can happen really in any part of the skull base. It's not that they're specific to the posterior cranial fossa. Or are these lesions focal? So are they involving the clivus, or are they off midline? Are they actually involving the bone themselves, or are they involving the cranial nerve? And we're going to tailor our differential based on the epicenter of the lesion. So now we're going to focus on some cases. So this is a case who came to us last year, and it's a 15-month-old who came in with recurrent otitis media, and she had bilateral periorbital ecchymosis, or raccoon eyes. And the patient has had intermittent bruising around one or both eyes for the past 6 months for an unknown reason. So you might expect that this patient actually is going to get worked up for non-accidental trauma, and that was reportedly negative. So the patient was referred to otolaryngology for bilateral tympanostomy tubes, and essentially was recommended to have some imaging after they consulted with a pediatric specialist. So this is the patient's images. And so we can see here that we've got, if you take a look at the brain parenchyma actually looks normal. We've got normal CT attenuation, normal vasculature, but what we can see is, if you take a look closely, that the dural venous sinuses are uplifted from the bone. They should be resting nicely along the bony surface, and we can see that there's this diffuse soft tissue that is essentially uplifting that dural venous sinus. If we actually take a look at the bone windows, we can see that there's this permeative, spiculated appearance of the entire skull base. So not just involving the posterior skull base, but also the middle cranial fossa and the anterior cranial fossa. So we can take a look at this patient's MR, and we can see that we've got this transspatial infiltrating enhancing process that's filling the temporal bones. So this patient actually didn't have otitis media. They actually had some soft tissue substance actually filling their middle ear cavity. So not only is this abnormality filling the temporal bones, but it's also involving the clivus and the anterior skull base, as well as the middle skull base, or the central skull base. And so we have to think about our differential diagnosis here, and what we have is an extensive infiltrative transosseous skull base mass in a young child with aggressive features. So we can really divide it into three different sort of general categories. We can think about our diffuse processes, including leukemia, lymphoma, and then metastatic neuroblastoma. We want to think about multifocal or focal lesions, including leukemia, e.g., fibrous dysplasia, and metastatic neuroblastoma, or potentially unifocal, so rhabdo and Ewing's. So we're going to go through the differential and take a look at the different sort of features of each one of the things on the differential. So this is a 5-year-old who actually came in with a left 6th nerve palsy. And we can see on our bone windows how we have this permeative lesion that's actually destroying the clivus. And we notice here that we've got a very large soft tissue component that is extending into the posterior cranial fossa. And we can see that it's enhancing, and it's doing that sort of thumbing the pons. And we can see that this patient actually was diagnosed with a Ewing sarcoma. And so this is a very aggressive small round blue cell tumor that typically arises in bone, and it's the second most common primary malignancy in children after osteosarcoma. And the most common appearance is a lucent, ill-defined intramedullary lesion with a permeative or moth-eaten kind of appearance. So this is a different patient, a child with a headache, and we can see that this patient actually has multiple lesions. We've got a lesion along that posterior skull base. We have a second lesion within the clivus and central skull base, as well as a lesion along the orbit. And so this patient actually was diagnosed with leukemia and had essentially granulocytic sarcoma. And essentially it's the multifocal nature of this, this disease process that can sort of steer you into that direction in terms of leukemia. There's extensive marrow involvement, and you can actually have a very spiculated kind of appearance on our bone windows. This is another child who came in with recurrent otitis, and so although this lesion doesn't specifically involve the posterior skull base, I think that it illustrates a point that this lesion on CT is lytic, so not like the appearance that we have in our index case, but we can see that we have some fluid or soft tissue within the middle ear cavity and this large soft tissue component. So this is a case of Langerhans cell histiocytosis, and essentially the key differential is this lack of periosteal new bone formation. This is another child with headaches, and we've seen a couple of different cases, examples of this in previous talks. This very aggressive sort of appearance on MR where you have expansile bone with both low signal on T2 and high signal on T2 with areas of heterogeneous enhancement. And of course, this complementary nature of CT can really help us with a differential diagnosis in this example where we have fibrous dysplasia. So characteristic ground glass appearance on CT helps us with this diagnosis. So this is a case of metastatic neuroblastoma, and we can see we've got this permeative appearance of the bone. We have the soft tissue involvement of the clivus extending in a subperiosteal location, and you can see here that it's the most common cancer in infancy, and the median age of diagnosis is 19 months. So now let's go back to our index case. So this is a 15-month-old. We remember that has recurrent otitis media with bilateral ecchymosis. And so we can see that this patient's got this infiltrating transspatial process, aggressive periosteal reaction, and this she was diagnosed with metastatic neuroblastoma. And so we can see this large soft tissue mass within the abdomen. So it's important for you to recognize that metastatic disease at diagnosis is up to 70% in patients. So you actually could be making the diagnosis of metastatic neuroblastoma based on the metastatic disease spread, not by the primary tumor. And so raccoon eyes, that's that characteristic clinical finding that is rare but can be present when metastatic neuroblastoma involves the orbits. So now we're going to move on to posterior skull base in the adult. And I like to think broadly first, and so we have all these categories: tumor, vascular, infection, inflammatory, and our don't touch lesions. And of course, we've got our laundry list of extensive differential diagnosis. And so as Rick had mentioned in his talk, it's not useful to essentially list all of these things, but it's important to at least consider, can they be on the differential? And then we're going to tailor it based on the specific location. And so the clivus, of course, shares sort of a common wall with the posterior skull base. And so we're going to go through my series of cases here, and we can use what Rick has mentioned in his talk and see how it can help us in our index case. So this is a 67-year-old who's coming in with diplopia. This is a case that I saw a couple weeks ago, and this patient actually had a stroke CT. That's what they were transferred to our hospital for. They were worried about a stroke. And so the first thing that I saw was I look at the bone windows first, and I can see that there's a mastoid effusion. And so my eye immediately goes anteriorly, and I can see that there's enlargement of the pterygopalatine fossa. And I look at my soft tissue windows, and I see that there's some soft tissue filling the pterygopalatine fossa. I look on my sagittal bone windows, and I can see that there's actually involvement of the clivus. This patient goes on to get an MRI, and we can see that there's this diffuse marrow replacing process involving the clivus. There's essentially a dural thickening along that posterior margin of the clivus. And of course we see and we can confirm this soft tissue in the cavernous sinus and in the pterygopalatine fossa. So when we think about our differential, we can think about Mets, myeloma, lymphoma. That's pretty much going to be on any differential that you want to think about, at least consider in any skull base lesion. Chordoma and chondrosarcoma, we're going to think about fibrous dysplasia, macroadenoma, meningioma, etc. So when we talk about location and we want to take a look to see, do you have a lesion actually involving the clivus intrinsically, or is it spread from the pituitary gland posteriorly, or is it spreading from the nasopharynx? So we've got a couple of different cases here, and we can see here that we've got our normal comparison. And one of the key findings that you want to take a look at any imaging study of the brain, you want to make sure that you concentrate on the normal fatty marrow within the clivus. You want to make sure that that is present on all your patients, because this is going to be the one sequence that you may actually be able to identify the pathology. So this is our index case, and then we can see that all of these patients have clival lesions. And on the surface, you might say, oh, well, I can't really tell the difference between all of these, but we're going to look and see if there are any specific imaging pearls that can help us with the differential. So of course, if you've got a history of a patient that has a known primary cancer, so in this case metastatic, or in this case breast cancer, we're going to be looking for Mets. And oftentimes we're concentrating on, is there intracranial metastasis? But we really should actually also interrogate the skull base. And so we can see here that we don't have any evidence of intracranial Mets, but if we look at the central skull base and the clivus, we can see that we've got something that's enhancing. Now your eye may not actually pick up on that, but you can clearly identify it on that sagittal T1 weighted sequence that is clearly seen on this sagittal image. So we notice here that the pituitary gland is normal, as well as the nasopharyngeal soft tissues. So this is a 52-year-old who's actually coming in with thrush, and the patient can't actually stick out their tongue for the ED physician to take a look at their mouth. And so they were actually worried about something involving the skull base because of that decreased tongue mobility. So in this patient, we can also see that there's total replacement of the clivus. That normal marrow signal is not seen, and on our axial images, we can see that there's this heterogeneous appearance of the clivus, both on our post-con images and on our T2 weighted images. We look at the rest of his imaging on our PACS, and we can see that the kidneys are totally replaced and expanded. And this is a patient that has lymphoma and newly diagnosed AIDS. This is a 23-year-old who's coming in with headaches, and we can see that there's this lytic lesion involving the clivus. And notice here how we've got these infiltrative margins on our CT image. And then notice how bright in signal this lesion is on T2. The enhancement is sort of variable, but in this case it's sort of minimal enhancement. And we don't really have very much diffusion restriction. It's actually primarily T2 shine through. So we've got a lytic lesion, midline location, and it's very bright on T2. So this is an example of a chordoma, sort of classic imaging appearance of a chordoma. So it's a rare locally aggressive tumor. It's primary bone tumor, and it's of a notochordal remnant, and it can occur anywhere from the clivus to the sacrum. There are two different subtypes, the typical or the chondroid chordoma, and the chondroid behaves a little bit more like a chondrosarcoma, and it occurs most often at the spheno-occipital synchondrosis, and so that's why you see it often at the junction between the sphenoid bone and the occipital bone. But when it gets larger, it sort of distorts all the anatomy, so it's tough to make that anatomic localization. Treatment is surgery and post-op radiation. So this is a 46-year-old who's coming in with facial pain, and we can see, we've seen a couple of examples of this already, but we've got this expansile appearance of the clivus. We can see that it's enhancing on our post-con image, and it's sort of heterogeneous on T2. We can make the diagnosis of fibrous dysplasia. This is a different patient, a 45-year-old who's coming in after a carotid endarterectomy, follow-up routine CT angiogram of the head and neck, and we can identify that this patient has something else going on. So we can identify that there's this permeative appearance of the clivus. Notice here how that permeative appearance is actually along the outer margin of the clivus, and the internal part is actually a little bit more preserved if you compare it to the sort of outer cortical margin. And we can also appreciate that there's this extensive soft tissue within the nasopharynx. On MR, we can see that there's this total replacement of the clivus as well as C1 and C2, heterogeneous signal on T2, enhancement, and then, of course, very FDG avid. This is a case of nasopharyngeal cancer. A different patient, a 59-year-old who's coming in with bitemporal hemianopia. We can see this lesion not only involves the clivus, but actually extends more into that central skull base. On our sagittal T1 sequence, we can see that there's this total replacement of the clivus, and it's extending posteriorly to cause mass effect on the brainstem. What we notice here is that we've got mass effect on the optic chiasm, explaining the bitemporal hemianopia. And as Rick mentioned in his talk, we actually don't have a normal pituitary gland. And so here we can make the diagnosis of a pituitary macroadenoma because we're looking at the sella and we want to see is that normal pituitary gland present. This is a great case that I saw a couple weeks ago. This patient actually, only symptoms were visual loss, which is astounding to me. So we have this large soft tissue mass that is extending along that posterior margin of the clivus. We can actually see that there's total marrow replacement of the clivus. Notice how even despite how big this lesion is, the sella is actually preserved in terms of the bony architecture, but it does extend into the sella and sort of obliterate the pituitary gland. And notice here how we have extension into the orbit, as well as extension along the nerves into the internal auditory canal, and even inferiorly through the skull base, through the hypoglossal canal. So this was a giant sphenoid wing and petroclival meningioma. This is another case, a 45-year-old man who's coming in with a history of tinnitus, and we saw this incidental lesion. And so we can identify here that there's this lytic lesion along that posterior margin of the clivus with sort of a well-defined cortical margin, and we can see that there's this tiny little punctate focus of calcification sort of centered right within it. Notice here how we have a very well-defined border, and no enhancement. And then on the sagittal reconstruction of our Fiesta sequence, we can see that there's a stalk that connects this external or this component that's just adjacent to the clival component. So this is an entity called Echordosis ficellifolia, and this is essentially a congenital benign hamartomatous lesion derived from notochordal remnant, and it typically occurs at that spheno-occipital synchondrosis, very similar to the chordoma. And so the imaging is nonspecific, but it's generally dark on T2, dark on T1 and bright on T2, and it does not typically enhance. And the thing that can help us make that differential is when you see the stalk-like connection to the clivus. But because it occurs in the same location as a chordoma, we want to at least consider following this to make sure that there's stability of this finding. So now back to our case. So 67-year-old with diplopia and stroke, and we can see here that in this example that we've got total marrow replacement of the clivus. We have this dural enhancement that is extending posteriorly. We see that the pituitary gland looks normal, but we also notice that the nasopharyngeal soft tissues are abnormal. And so this patient has a diagnosis of nasopharyngeal carcinoma with perineural tumor spread and extension through the clivus. So now let's take a look with our last couple minutes at a couple of other entities. So we have off-midline clival lesions. So of course we're going to think about all the other things that we've talked about, but we want to consider chondrosarcoma on that differential because of the off-midline location. So this is an adult who presented with sinus symptoms, so had just routine sinus CT, and we saw a lesion incidentally off midline along that inferolateral part of the clivus at the level of the petrooccipital synchondrosis. So we can see here that the margins are somewhat ill-defined, and potentially you could try to hallucinate some matrix, but I'd say that the matrix component within this lesion is not very significant in this particular case. So the patient went on to get an MR, and we can see that the lesion is very bright on T2, and it enhances. And we can see that this is an example of a chondrosarcoma. So it's also a rare tumor. It's the imaging appearance is T2 hyperintense, and the matrix is typically this rings and arcs kind of configuration. And 82% of cases occur off midline. So that off midline location and that very bright signal on T2, that's going to be those are the features that are going to help you think and consider chondrosarcoma on your differential. So chordoma versus chondrosarcoma, chordoma typically midline, and then chondrosarcoma typically off midline. So now finishing up with the jugular foramen, we want to take a look at a couple of different cases in this anatomic location. So the jugular foramen is divided into two major compartments, the pars nervosa, which is more anterior in position, and that houses the inferior petrosal sinus and cranial nerve 9. You can remember that by N for nervosa and 9. Pars vascularis has the vagus nerve and the spinal accessory, vascularis, as well as the sigmoid sinus, so 10 and 11. So you have to think about nerves in the jugular foramen, 9, 10, and 11, and you want to think about diseases that affect those cranial nerves, and patients are potentially going to be presenting with abnormalities affecting those nerves. Course of the vagus nerve, we want to think about, obviously, starts at the brainstem, and it exits through the jugular foramen, and then it takes the recurrent laryngeal nerve, travels underneath the aorta, and then the right recurrent laryngeal nerve travels underneath the subclavian, and then ultimately extends to the level of the larynx. So case 3, we're going to take a look at this patient who's coming in with hoarseness. And so we can see here that this patient has an expansile lesion involving the jugular foramen. And the patient came in with hoarseness, so they ended up getting a neck CT. And we can see that there's this medialized left vocal cord. So on MR, we can see that the lesion is actually a little hard to see on this routine MR image. So we can see that the lesion is enhancing after contrast. It's a little bit bright on T2 and actually hard to see on our Fiesta sequence. So in terms of our jugular bulb differential diagnosis, of course, all the things that we talked about involving the bone, but other things that we want to consider are paraganglioma, meningioma, and schwannoma. So jugular diverticulum is essentially a don't touch lesion. It's you can just have asymmetry in the size of the jugular bulb, and you can potentially also see diverticula coming off the jugular bulb. So that's just a classic case of a diverticulum. Incidental lesion, don't touch. This is a patient who's coming in with pulsatile tinnitus, and we can see that this patient has a lesion involving the jugular bulb. And notice here how the osseous margins are very infiltrative. And this lesion extends through the floor of the hypotympanum with a component that extends into the middle ear cavity. This lesion has an extensive tumor vascularity on our angio sequence, is bright on T2, demonstrates enhancement with this salt and pepper appearance. So this is a classic paraganglioma, a glomus jugulotympanicum, because it involves the jugular bulb and extends in the tympanic cavity. This is another patient who's coming in with headaches, and we can see that this large dural base mass, and we notice here on the CT how we actually have bony expansion and calcification within the soft tissue component. And we also have thrombosis of the right transverse and sigmoid sinus. So this is a meningioma. So on the differential, we want to think about a jugular foramen schwannoma. We can see this very smoothly marginated lesion enhancing, and that smooth margination can help us with that differential of a schwannoma. This is another patient who's coming in with hoarseness and tongue deviation, and we can see this very large lytic lesion involving the posterior skull base, very hypermetabolic on our PET sequence, and we can see the tongue sagging related to that 12th nerve palsy. On MR, we can see that the lesion is sort of relatively dark on T2, enhances homogeneously, and this is a plasmacytoma. Another patient with facial pain, we can see that this patient has a mirror replacing process, not of the colitis, but actually of C2, C3, and C4. And the lesion is actually hard to see within the skull base, but very readily visible on our PET sequence, metabolic. So this actually was an example of lymphoma. And the patient came in with facial pain, and we can actually see a separate lesion within Meckel's cave. Another patient with breast cancer, we can see this very large lytic lesion involving the jugular bulb and foramen, enhancing bright on T2. This was a breast cancer metastasis. A different patient who's coming in with hoarseness. Now we want to think about the recurrent laryngeal nerve. So we have this medialized cord, but also want to think about lesions within the thoracic cavity, and this turned out to be a Pancoast tumor. So let's look back at our index case. This is a patient with hoarseness. We can see this patient actually had a diagnosis of thyroid cancer, and this was metastatic medullary thyroid cancer. So in terms of our talk today, hopefully you have an understanding of the relevant anatomy of the posterior skull base. We can organize the pathology based on anatomic location, and then have a short